All right, hello and welcome to today's Better Hearing webinar. Today we are going to be talking about considerations for atypical hearing losses. I'm Caitlyn Whitson. I'm an audiologist and the clinic manager at the University of North Carolina Hearing and Communication Center in Chapel Hill, North Carolina. Our clinic is a nonprofit practice of faculty doctors of audiology, and we serve as a training clinic for doctoral students who are studying at UNC Chapel Hill to become audiologists. We work primarily with adults doing diagnostic hearing evaluations, fitting hearing aids, and fitting hearing protection. We work with all hearing aid manufacturers, and we run on an unbundled or fee-for-service business model. In addition to adult diagnostics and hearing aid fittings, we also offer balance or vestibular specialty testing and tinnitus specialty testing. Pictured there is our main clinic location off Farrington Road in Chapel Hill, and we also have two other satellite clinics in the area. For appointments, you'll call the number at the bottom of the screen or send an email to the email address there, and we will get you scheduled at one of our 3 locations. Please subscribe to our YouTube channel if you haven't yet, because all of our Better Hearing webinars will be there, and you can look through all of them, and like us on Facebook as well, and the link is at the bottom of the screen there. If you're on our YouTube channel, then you've already found us. So please subscribe to our channel and like this video if you find it helpful. But today we're going to be talking about hearing loss and how hearing works in general. We'll talk about our typical presentations of hearing loss and then some less common configurations of hearing loss. And we'll end with other considerations to think about, both for our typical hearing loss configurations, but that are especially important when you're working with more rare forms of hearing loss. So hearing works by sound moving through the ear, and it moves through 3 parts: the outer ear, which is our ear canal, the middle ear, which has our 3 bones, and then our inner ear. And the inner ear is divided into 2 parts: the hearing organ, that's called our cochlea, and the balance portion of the inner ear. And these are our semicircular canals, and that's our vestibular system. But as sound comes through the outer ear, it travels through the bones of the middle ear and comes into the cochlea, where the sound is picked up by very small hair cells, and then it travels up the nerve to the brain. So if there's a problem in any of these parts of the ear, then we don't get the sound to the brain. So the brain ends up either not receiving it entirely or possibly misinterpreting a sound. That is hearing loss. And we're going to talk more about that in detail, because the cochlea is really important. And the little microscopic hair cells inside are what picks up the sound, but they're very susceptible to damage. And this could be either age-related damage or damage due to noise. Those are the top 2 causes that our hair cells die off. And when they die off, they don't grow back. This causes a form of hearing loss called sensory neural hearing loss. And that's the most common type of hearing loss. So there are 3 types of hearing loss, sensory neural being the most common. And this is a problem with either the cochlea or the nerve or both. Medical intervention is not typical for this type of hearing loss. So medical intervention would be something like a surgery to correct it or taking medication to resolve it. Typically, sensory neural hearing loss is treated with hearing aids or a cochlear implant. A conductive hearing loss occurs when there's a problem with the outer or middle ear part of the ear. And this is when sound is not able to be conducted through that system. And this is usually due to some kind of physical blockage. This type of hearing loss can sometimes be treated medically, either with medicine or surgery. So the most common example we think of are an earwax blockage, which can be physically removed, which allows sound to then travel through, or maybe an ear infection causing a buildup of fluid in the middle ear. You can either treat it with antibiotics, or in severe cases, a surgeon will create a hole in the eardrum that allows the fluid to drain. A mixed hearing loss is a combination of these two types of hearing loss. So someone could have a sensorineural hearing loss, perhaps due to age or noise exposure, and have an ear infection on top of it. So they would have a mixed hearing loss. One thing to keep in mind when we're talking about hearing loss is that there are two aspects to how the brain processes sound. There's a detection of sound, and there's also the processing. So detection is either you hear it or you don't hear it. But processing is extracting meaning from what's heard. So if the ear has hearing loss, it may make it hard to detect sounds. And if it's hard to detect certain sounds, that can make it more difficult for the brain to accurately process the sounds. So as an example, your ears might detect the speech sounds in the sentence, "Let's go to the blank." And it might hear the "or" of the last word, but it doesn't get the first part of the last word. So the brain may try to fill in the gaps for what the ear is not detecting, as possibly "let's go to the store" or "let's go to the shore." So there's a difference here with detection and processing, but they're both closely intertwined. So having hearing loss can lead to compromised speech perception, which then leads to increased effort to communicate. And when it takes a lot of work to hear, then we tend to not want to work so hard over time. That means we become more withdrawn socially. So we see reduced social engagement from people with hearing loss who don't wear hearing aids or cochlear implants. That can increase our sense of loneliness and depression. And those things have correlations now with cognitive decline, physical decline, and overall poor quality of life. So current research is looking at how do we stop this? How do we mitigate these risks? And how do we improve quality of life as we get older? Do hearing aids help? And when we think about hearing aids as amplifying sounds, well, how can they help if we're working with lost hair cells in the inner ear? Hearing aids are not perfect. Anyone that wears hearing aids will tell you they still have some trouble in noisy environments, but they do help. And they do that by making sound louder. So I'm going to pull out my laser pointer. So in a healthy ear, we've got all of our hair cells there. Each hair cell is tuned to a different frequency. So when that sound comes in, the frequency finds its corresponding hair cell and essentially causes it to move, which then takes the sound and sends it up the nerve. But when we have a loss, now where that frequency would have come in before, there's nothing there to detect it. Well, a hearing aid turns up that sound to make it a bigger sound wave, which means now instead of just affecting this portion of the cochlea, now it'll affect a larger surface area. And there may still be some hair cells remaining that can pick up that sound. So with a hearing aid, we get better detection of sound. Hearing aids also do some filtering of the sound before it goes into the ears. So they try to separate out noise from speech. They focus in specific directions, And they do this automatically based on the sounds around you. This cleaning up or filtering of the sound makes it easier for the brain to process what is heard. So before we get into talking about what an atypical hearing loss looks like, let's discuss what a typical hearing loss is like and how it's treated. And the most common form of hearing loss is a high frequency sensory neural hearing loss. This is also referred to as a sloping hearing loss. And for everyone watching right now, most of you have this type and configuration of hearing loss. It's named sloping because it has this sloping shape on an audiogram. So to read this audiogram, we're looking at low frequency or low pitch sounds on the left. And then as we move to the right, they become higher and higher in frequency or pitch. Soft is at the top and very loud is at the bottom. For each frequency, we're marking how much volume is needed before this person just barely hears the sound. The red circles are the right ear and the blue X's are the left ear. The gray area shows where normal hearing ability lies. So this person has normal low frequency hearing and a moderately severe to severe high frequency hearing loss. This configuration of hearing loss is typically caused by age, noise exposure, medications that are toxic to the ears. They could be caused by a tumor or a growth on the acoustic nerve called an acoustic neuroma. They could be caused by a virus or an infection that gets into the ear. So not a middle ear infection, but an infection that gets into the inner ear. Or it could be caused by genetics. Either you could be born with it or it can progress throughout your lifetime. Some common signs and symptoms that you have a high frequency hearing loss is you have trouble hearing consonant sounds in speech. It sounds like people are mumbling. You need to turn the TV or radio volume up louder, but making it louder doesn't necessarily make it more clear. A person with a sloping hearing loss will do pretty okay and quiet as far as communication goes, but they'll have more trouble when there's background noise. They often misunderstand what's said, and that's because of the difficulty with hearing the consonant sounds. This person may likely also hear high-pitched tinnitus along with the hearing loss. And over time, if the hearing loss goes untreated, this person is going to start to withdraw from social situations because it's really difficult to hear or to understand. So a sloping hearing loss is typically treated with 2 of 3 what's listed here. It'll be fitted with typically a hearing aid first. And with this configuration of hearing loss, we really want an open fit hearing aid. That means an open fit refers to keeping the ear canal open. Because someone with a sloping loss has such good low frequency hearing, we want to use that natural hearing and only amplify the high frequency sounds. So for them to use their natural hearing, we need to keep the ear canal open. Because of that, a RIC style hearing aid, which is what's pictured here, is the best type of hearing aid for this loss. A custom hearing aid, meaning a hearing aid that's completely in the ear, could be used if the ear canal is large enough. So if someone has a really small ear canal, there's just not enough space to fit the hearing aid and have a large enough vent or opening going through the hearing aid to allow sounds to naturally pass through. So on a larger ear canal, that may be possible. If a high frequency or sloping hearing loss progresses into the severe to profound range, they may only get minimal benefit from their hearing aid. and that puts them into the cochlear implant category, or EAS, which is electroacoustic stimulation. I have another webinar that dives into the details about cochlear implants and electroacoustic stimulation. So I encourage you to check that out if you haven't seen it yet. Either one of these amplification options will be combined with communication strategies. So a hearing aid isn't going to solve all of our communication problems. Hearing aids don't regrow those hair cells. They don't give you back normal hearing. So whenever possible, you want to reduce background noise to make it easier to hear the speech. You want to speak face to face whenever possible. If you're the one doing the speaking, you want to get the listener's attention before you start talking. So tap them on the shoulder or say their name. You also want to speak clearly, not yelling, not exaggerating your speech, but enunciating well. And try to avoid reverberant environments or add soft furnishings to the area to reduce echoes if possible, because echoes are basically like background noise to the ears. It makes it difficult to understand. So now that you have an idea of hearing and our typical hearing loss, let's look at some more rare configurations of hearing loss. So one of the more common configurations of the rare ones is called a reverse slope hearing loss. And it's named that because it's the opposite of a sloping hearing loss. In a reverse slope hearing loss, we have more loss in the low frequencies. This is also referred to as a rising hearing loss or a low frequency hearing loss. Of all of the people with hearing loss in the US and Canada, about 1 in 12,000 of those will have a reverse slope hearing loss. The causes of this type of hearing loss could include your genetics. You could be born with it, or it could progress later in life. Could be due to a viral infection or bacterial infection in the inner ear. Could be due to Meniere's disease, heart disease. If it's a conductive hearing loss, it could be due to a middle ear infection, or it could be idiopathic. There are some reverse slope hearing losses that we just don't know what is causing them. Some signs that you have a reverse slope hearing loss are difficulty hearing low pitch sounds like men's voices, the bass in music, or the vowels in speech. People with a reverse slope hearing loss do not have as much difficulty in background noise compared to the high frequency hearing loss group. And that's because they hear the consonants in speech pretty well. So they get the clarity from the speech. They're just missing the power and the volume behind it. A lot of the people with a reverse slope hearing loss may not realize that they have hearing loss, depending on the severity. And it can be difficult to diagnose because they may not realize that they're missing low frequency sounds. The onset of a reverse slope hearing loss could be congenital or from birth. It could be progressive, or it could be a sudden onset. As far as treatment, if you have a sudden onset hearing loss, you should see an ENT physician right away, because there may be some medical intervention that they can do to recover the hearing, depending on what the cause of the hearing loss is. Otherwise, if it looks like it's a permanent hearing loss, the treatment is typically hearing aids and a combination of communication strategies. Reverse slope hearing losses are not typically treated with cochlear implants. A hearing aid could be an open or closed fit, depending on the severity of the hearing loss. And despite having really good high frequency hearing, a little bit of amplification in this region from the hearing aid can be helpful to improve speech understanding from the hearing aids. Cookie bite configuration is another configuration, so named because it looks like a bite out of a cookie on the audiogram. So this is also referred to as trough-shaped or a mid-frequency hearing loss. Someone with a cookie bite hearing loss can hear the bass, the low frequencies pretty well, and they can hear the high frequencies pretty well, but they're missing the middle range. Causes are almost always genetic for this type of hearing loss, and it might be from birth or it might be later onset, and it might be progressive and get worse with age. It depends on the cause of the genetic and which genes are involved. Some signs that you may have a cookie bite hearing loss are that you would have more difficulty in background noise compared to in quiet. You have trouble understanding speech without being able to see someone's face, so without visual cues. You're having to turn up the volume on the TV and radio more than you used to. And we often see a progression of this type of hearing loss in adulthood in the 20s to 40s. After you get past about the age of 65, we can start to see an age-related hearing loss on top of the cookie bite hearing loss, and we start to see the high frequencies decline. So as we get more advanced in age, it can start to look more like a sloping hearing loss, but it would be more severe than just an age-related hearing loss alone. There's no medical intervention for this type of hearing loss. There's no surgery or medicine that can fix it. Treatment is typically an open fit hearing aid and communication strategies. Cochlear implants are not typically used for this type of hearing loss. A reverse cookie bite is the opposite of your cookie bite configuration. It's also referred to as a peaked hearing loss. People with a peaked hearing loss will have better mid-frequency hearing. They have more trouble hearing the bass and the treble, so the low of the lows and the high of the highs. This means they'll need to turn the TV and radio volume up louder, and voices will not only sound muffled, like in our high frequency hearing loss group, but they will also sound softer because they've lost the bass range of the speech. And our treatment for this, again, is typically hearing aids and a combination of communication strategies. Cochlear implants are not typically prescribed for this type or configuration of hearing loss. The last atypical configuration that we'll talk about today is a unilateral or asymmetric hearing loss. And this is where one ear is better than the other. With a unilateral hearing loss, the person will typically have normal hearing in the better ear. And with asymmetric, they may or may not have normal hearing in the better hearing ear. Sometimes people refer to a unilateral hearing loss in the severe to profound range as single-sided deafness. And that is where essentially there's almost no hearing in the poorer ear. People with unilateral or asymmetric hearing loss will have difficulty localizing sound or telling where it's coming from. They'll have a lot of difficulty hearing in background noise. They'll have difficulty hearing soft sounds or soft speech, even if their better ear, it has normal hearing. This person, if they have good hearing in their better ear, they will do okay communicating in quiet in a one-on-one conversation. There are a few different treatment options for unilateral or asymmetric hearing loss. So you might wear 1 or 2 hearing aids. You might wear a cross or a bicross. And this is something to treat single-sided deafness. Cross stands for contralateral routing of the sound. And what this is, it looks like a person is wearing 2 hearing aids. One of them is a microphone, that takes sound on the side where that ear really has no good hearing left. It sends the sound over to the opposite side where they have better hearing, so that this person has better awareness of sound coming from the poor side. The better ear may or may not have hearing loss. A BHW is a bone-anchored hearing aid that's placed surgically that essentially works like a cross. It's taking sound from the poor hearing side, but rather than sending it to a hearing aid, it's anchored to the bone in the skull, which vibrates the whole skull, including both of our inner ears. And so the sound is routed to the better hearing ear through the bones of the skull directly. Both a cross and a BHW do not provide sound to the poor hearing ear's side. It's only putting sound in the better hearing ear. So it is not binaural hearing. For someone who has single-sided deafness where they cannot use a hearing aid on the poor side, a cochlear implant is really the only option to give hearing back to that side. This is a surgical option. Because there's a variety of treatment options for this configuration of hearing loss, the treatment options are typically reviewed both by an ENT physician and an audiologist with the patient, and they figure out the best option for that person. Now I want to talk about other things to keep in mind, both really for our typical hearing loss configurations, but it's especially true for those who have these other rare configurations of hearing loss. So if we think about the testing, the diagnosis is really important. So not every hearing aid clinic or center is created equally. There are audiologists who have a bachelor's degree as well as a doctoral level degree, and they're trained to diagnose hearing loss and balance disorders in both adults and children, and for the typical and the more rare cases. There are also hearing aid centers that follow a more retail model, and those are staffed by hearing aid dealers or hearing instrument specialists. They do not have the same level of training as doctors of audiology. So if you know that you have one of these atypical forms of hearing loss, I caution you about going to a hearing aid center because they're trained on the more typical configuration of hearing loss of that sloping age-related hearing loss. When you come in for a comprehensive evaluation, the testing should include otoscopy, which is looking in the ears, air conduction and bone conduction pure tone thresholds. I have seen people bring in hearing tests from other clinics. Typically, they're from hearing aid dealers or hearing aid centers that do not include bone conduction testing. You cannot determine the type of hearing loss without bone conduction thresholds on the test. So this is a necessary part of the test. Speech testing, speech and noise testing, and uncomfortable loudness level testing. Those last two that I mentioned are italicized there. And I did that because those are two tests that are not routinely run for our comprehensive evaluations. Here at the Hearing and Communication Center, we do both of those tests standard before we consider what type of hearing aid we would fit on you. Other tests that we won't go into detail about what exactly they are today, but that should be included in the test battery if it's indicated or if medically necessary, are emittance testing, which includes tympanometry and acoustic reflexes, and DPOAE testing. At the end of the test, the provider should go over the results with you, and sometimes referrals to other disciplines or other medical providers are necessary. So like a referral to ENT if you have a difference between your ears. After the diagnosis of hearing loss is made and any appropriate referrals are made, if a hearing aid seems like the best treatment option for you, then you come back for a hearing aid selection appointment. And when you have an atypical hearing loss, or your typical hearing loss, really, we are looking for a hearing aid that's going to provide the appropriate amount of amplification for your loss. We want something that's going to fit comfortably for 8 or more hours a day, every day. It should be easy to put on, and it should stay on well throughout the day. If you need accessory devices to supplement the hearing aids, we need to pick a hearing aid that's compatible with those. So some people need to use a microphone so that other people can talk into it in a noisy environment and the person can hear that speech more clearly. So the use of assistive devices depends on the severity of your loss and your listening needs. A hearing aid needs to match your lifestyle. Do you want something that's rechargeable or uses a disposable battery? Is it Bluetooth compatible? Are there adaptive features like background noise management and directional microphones? And of course, your budget should be taken into consideration as well. So an audiologist is here to help you find a hearing aid that's the best match for you, for your hearing loss, and your lifestyle. Your audiologist will also give you the follow-up care that's needed with fitting hearing aids to ensure that you're getting the most benefit possible. Because it's really important to remember that a hearing aid is just a device and it can be programmed many different ways. It can have different earpieces attached to it. So it's really the audiologist's work with you that ensures that it's working appropriately. The hearing aid is just the tool. So once we've chosen a hearing aid, at the fitting is really where the magic happens. And hearing aid verification is a really important part of a hearing aid fitting. If you've seen my other webinars, you've heard me talk about this a lot, but I talk about the importance of real ear measures all the time. Real ear measures are the only way to verify that the hearing aids are set appropriately, that they're loud enough to overcome your hearing loss, but they're not too loud and uncomfortable. This picture of this gentleman on the right is an image of him set up undergoing real ear measures, where we put a small microphone tube in his ear, and we've got the hearing aid set on top going into his ear, and that's connected to this test box and computer here. This allows us to see on the screen exactly what he's hearing from the hearing aid. And frequency by frequency, we can turn the hearing aid up or down. So this is an example of what he's looking at in front of him. So this is the blue line for the left ear. So the line is higher in the high frequency region because there's more hearing loss in that area. Soft sound is at the bottom, loud sound is at the top on this graph. It's a little bit busy, but these orange lines or crosshairs are his prescription for his hearing loss. We call these prescriptive targets. The hearing aid output for each frequency should match these targets, ideally. This bold orange line cutting through the middle here and has a hump there is the output of the hearing aid that we're measuring with the microphone in his ear. And because this bold line is not matching closely to these targets, that tells us that the hearing aid is too soft. So we would go in frequency by frequency and turn it up the appropriate amount. So this is a hearing aid. If someone put it on their ears and they had this loss, they would say it's not working at all, because to them it wouldn't be. This is an example of a hearing aid that is well matched to targets. So you see our little crosshairs. The fuchsia is soft speech. Green is a little bit louder. It's average conversational speech. The blue is loud speech. And we see our bold line, the output of the hearing aid, tracking along nicely with our prescriptive targets. So in your typical hearing loss category, most people have this sloping high frequency hearing loss. Most computer software for hearing aids is going to be based off of that expectation that most people have that hearing loss and that they have an average sized ear canal. Only about 30% of audiologists are running this measurement and verifying hearing aids. And I can't stress to you the importance of running this measurement, but not only for our sloping hearing loss category, but especially so when you have an atypical hearing loss. Sometimes our fitting strategies with these more rare configurations of hearing loss does not exactly match our targets, because some of these targets are also based on a high frequency hearing loss. And so we really need to know what the hearing aid is putting into each person's ear. And that's especially true when you have a less common type of hearing loss. So if you take away anything from today, I want you to remember that the majority of people with hearing loss have a high frequency or sloping sensory neural hearing loss. The less common configurations of hearing loss include reverse slope or rising hearing losses, cookie bite or reverse cookie bite hearing loss. And I forgot to add unilateral or asymmetric hearing loss to that list. A proper diagnosis from the beginning is key, because a lot of your atypical hearing losses can be misdiagnosed or just missed entirely. You should see a licensed doctor of audiology or an audiologist for your diagnostic hearing evaluation. Hearing aids are an appropriate treatment for most forms of hearing loss, though some configurations of hearing loss will also need a medical evaluation from an ENT before fitting a hearing aid. Real ear verification is a necessary part for every hearing aid fitting, but especially for those with atypical hearing loss configurations. And remember that hearing aids are only one tool used to treat hearing loss. We still need to employ good communication strategies, and some assistive devices may also be recommended in your treatment or oral rehabilitation plan. So at this point, we'll go to the chat box to answer any questions. I'm going to stop our recording from YouTube. So if you're watching this on the live presentation, type your questions in the chat box now. If you're watching on YouTube, please give this video a thumbs up and subscribe to our channel if you haven't yet. Thank you.